Hello guys, my name is Hugo. I'm a second year medical resident in anesthesiology in Brazil, and today we are going to discuss about perioperative management of anemia. So the topics that we will be discussing today are: first, definition of anemia, screening of anemia, investigation, main causes of anemia, and treatment options, and we'll be discussing the treatment options before surgery and during surgery. This is a really important topic for anesthesiologists and physicians in general because anemia can be present in over 30% of surgical patients, even in elective procedure, especially especially women. So, especially women in the fertile period. Okay, so definition of anemia, according to the World Health Organization, is 130 grams per liter for men and 120 grams per liter for women. So, there's a little observation when we are talking about reference values for women because there are some reference that consider an underestimation for women and values even for women lower than 130 can be considered an anemic or pre-anemic state even for women. So there are some references that consider anemia 130 for both genders. Okay, so don't be surprised if you see that consideration in other article, for example. So, in the context of surgical patients, especially in elective procedures, the golden question is: should I screen all surgical patients? How and the screen is done? So, we're gonna talk about some guidelines and some. I mean, there are suggestions about how to screen these patients, and of course you will individualize your practice for it, for your patients. Okay, so it is really concerning for the anesthesiologist to know how much blood loss is expected in a surgery. So you need to be a close relation with the surgeon. You need to have basic understanding of the procedure that your patient will be put under, so you can estimate the blood loss of the procedure. Okay, so in this nice guidance, uh, according to the type of surgery that, as you can see here in this example, the nice guidance suggests the classification of surgery grades in these examples and minor, intermediate, major, complex surgeries. And according to the nice grades, you can classify the procedure that your patient will be put under. Okay, so if you have a minor surgery, no full blood count is actually needed. So if you have an intermediate surgery, it depends on the classification of the patient. So SL1 or 2, no full blood count. SL3 or 4, a full blood count will be needed. Concerning evaluation of anemia, other lab tests or image tests can be discussed and in another presentation. And all major surgeries need a full blood count for the screening of anemia. Okay, so there is another table here. As you can see, the procedures being classified according to the risk of bleeding. There are procedures with a low, very low risk of bleeding, moderate risk, and high risk of significant bleeding. So if you want to take a close look at this table, please be comfortable to stop the video and read all the examples in the table, okay? So let's continue. So now we're going to be discussing the main causes of anemia in these patients, which will be iron deficiency anemia, functional iron deficiency, that can also be called anemia of chronic disease, and B12 folate deficiency. Okay, so iron deficiency can be due to a lot of causes, but usually is associated with excessive bleeding, and it will be depending on the patients. For example, women, the menstrual bleeding is a great possibility for be losing blood, and there are other options such as gastrointestinal blood loss for the gastrointestinal pathologies such as cancer, especially for the elderly, or non-steroidal anti-inflammatory drugs abuse. So all these causes need to be searched and need to be collected with the patient with a good anamnesis. Another causes are reduced intake of the iron, diet deficiency in iron, poor absorption of iron such as Crohn's disease, celiac disease, or previous stomach intestine surgery including bariatric surgery. Okay, so another kind of anemia, the type of anemia that we need to discuss, functional iron disease, or also they called anemia of chronic disease. So in this type of anemia, you usually have a good amount of iron, but the tricky part is you can actually use it. Because of the chronic disease, the body is usually in an inflammatory stage with the release of abscessin that will block and will be in the middle of the use of the iron in the body. So anemia chronic disease is a result of this condition here, because you have a blocking iron release of the cells, you have a reduction in absorption of iron, and you have internalization, degradation of ferroportin enterocytes and macrophages. So these all result in anemia. There are several chronic diseases that are associated with functional iron deficiency, but I brought here to mention chronic kidney disease, congestive heart failure, rheumatoid arthritis, inflammatory bowel disease. So all these conditions you need to evaluate your patient to have um, a, a primary suspicion about the cause of the anemia in your patient. Okay. Another cause of B12 anemia is B12 or folate deficiency. As you can see, B12 deficiency is usually associated with a poor diet or poor absorption. A poor diet is seen in patients that are vegan, so they don't eat products from animals such as meat or eggs or milk. There are the sources of the B12 vitamin that humans can get. Another cause is poor absorption. That is associated with intrinsic factor. So you can have pernicious anemia, which is a condition that will cause the damage of peritoneal cells in the stomach, and these cells are responsible for producing the intrinsic factor. So if you don't have intrinsic factor, you don't have the poor absorption of the B12 vitamin on the intestine. Okay, so now about the folate deficiency, it is caused by a poor absorption of the vitamin, or the or for example caused by use of medicine, or you have states with high consumption of the folate such as pregnancy. So there are some medicines that we need to discuss that can cause folate deficiency, such as phenytoin, carbamazepine, gabapentin, and methotrexate. So you need to be aware if your patient is using those. So another causes of anemia, actually there are several other causes, but some some causes that you need to be aware of are sickle cell disease and thalassemias. Okay, so now we're going to discuss about the diagnosis of the patient. So once the anemia is identified, how do we need to proceed our screening? So the first thing you need to do is confirm the full blood count. It is reasonable to demand and to solicit another full blood count for the patient, and you will have some parameters such as mean volume, such the such as the hemoglobin levels, such as the corpuscular value, and there are other lab tests that you can solicit, can demand, such as iron studies, such as the renal functions, and according to your primary diagnosis is you can ask for TSH to evaluate thyroid. You can ask for a runny dipstick to check for blood loss in urine. You can also ask for colonoscopy if you are suspecting with a gastrointestinal disease. You could ask for a live functional test to screen for any other chronic disease that you'll be suspecting. Okay, so once you have the results, if you have a patient with low ferritin, with low T saturation, and a reticulocyte hemoglobin concentration low, you have a higher probability and you can diagnose the patient with iron deficiency anemia. So once you identify that, you will start the treatment that we'll be discussing later. If you have a patient with a ferritin level between 100 and a patient with low renal function, you can suspect if a functional disease due chronic renal failure. Okay, another option of if you have a patient with a high ferritin, a T saturation lower than 20, and a reticulocyte hemoglobin concentration higher than 30, normal B12 and folate, and possible raised CRP. There is a protein C reaction. So you have another case when you suspect of a functional iron deficiency. You also consider erythropoietin in this context. Okay, so if I have a patient with good ferritin levels, so there are no suggestion of iron deficiency, you have a patient with low folate or B12, then you diagnose the patient with B12 or folate deficiency. So, discussing about the treatment of iron and anemia deficiency, you have two options when it comes to taking iron. You can prescribe oral intake or IV iron intake. So the iron intake is just very tricky. You need to be uh, more watchful with your patient because there are some there are some concernings when it comes to its administration. For example, avoiding tea or eating phytate at the same time as iron because they will be reducing the iron absorption, or patient with intestinal disease that won't have a proper absorption of the iron. So how long? So these patients need to be reevaluated in 3 weeks, for example, to repeat the full blood count and to demand for reticular hemoglobin concentration to see if the levels of the iron are being increased, to see if the treatment is being successful. If not, you can switch to the IV iron. However, if you have such a hurry and the surgical procedure, for example, if the procedure is due in 4 weeks, it is reasonable to start the treatment with IV iron because the successful rate will be better. So, and to calculate this, you could use this formula, but it actually depends on the kind of pharmacology component that you'll be using. So it is reasonable to consult the medication information that you'll be prescribing to a patient. So, but you will be using the body weight of the patient, the target hemoglobin, the actual hemoglobin, and to the patient to calculate how much iron this patient needs to be taken parentally. Okay. So another treatment that we can discuss are the erythropoietin. Erythropoietin is especially used in patients with renal with renal disease. So the production of hemoglobin will be increased in the use of erythropoietin because the production in the kidney of a patient with renal failure will be a lot lower than the normal. So interpretive management. So for that, in patient with B12 or folate deficiency, you'll be of course replacing uh, replacing those vitamins. Okay, the imperative management of anemia. So the first thing you need to have careful. So the conversation with your surgeon is really important. You need to consider avoiding hypertension in your patient. You need to consider hemostatic agents such as tranexamic acid, aminocaproic acid, or even local hemostatic agents according to the procedure and availability of the local hemostatic agent. Another option, tourniquets that are usually used in orthopedic procedures. So another option to treat are the blood transfusion. There are two types, as we all know, allogeneic transfusion and autologous transfusion. I'm gonna I'm going to exemplify autologous transfusion because it's something if that you need to prepare, you need to plan beforehand the procedure. For example, in autologous transfusion, we have some options such as a predisposed autologous transfusion, a self-salvage transfusion, and acute normovolemic hemodilution. A predisposed is when you take the patient donate blood and it is storage in the bank in the blood bank, and if during the seizure the patient needs blood transfusion, the patient will be receiving its own blood. Okay. Another example is cell salvage, which is a procedure where during the surgery, the blood that is lost in the patient is suctioned through a machine and is reprocessed, and then it's retransfused to the patient in the procedure. Another option is the acute pneumovolemic hemodilution. So before the transfusion, the patient uh, you collect the blood bags of the patient, so the hemoglobin level of this patient will be lower. And once you do that, you retransfuse, you give this patient the volume that the patient lost in blood with crystalloid. So the patient will achieve its normal volemic state with these crystalloids. Okay, so during the surgery, the patient will be losing blood, will be losing less hemoglobin than than the patient would lose if he had not been in an in a hemodilution states. So during and post-operative, the patient will be receiving the concentrated blood back of its own blood to recover the, the blood that the patient had lost. So here is a video that you can guys check on MedStar Health. So in this case here, the patient will be losing its blood and will be processed, and there will be a reinfusion bag of the patient. Or in this case, you have a pre-deposit of the bag that will be retransfused in the patient, and non-blood liquid is given to the patient to a hemodilution state. Okay. So these are the reference for the lecture, a guideline for the measurement of anemia and the perioperative pathway of the Center for Perioperative Care, recommendations from the International Consensus Conference on Anemia Management in Surgical Patients, and the Perioperative Anemia Management of Saikat Mandal et al. So if you have any questions, please put in the comments and I'll answer as soon as I can.